dignitaries and the delegates.
Hello.
My presentation is on monoclonical blade laceration integrated with an angiocatheter cannula as a stent, a simple and inexpensive system. Myself, I'm Amit Parker. There are no financial interests. Any blade laceration, we should always have a suspicion of a canalicular tear. Any laceration involving a medial to the punctum should increase the suspicion, or if at all it is a widespread laceration, then medial to the pupil would be a better approach. So canalicular laceration is a discontinuity in the normal airway duct system and can result from a direct or an indirect trauma. It can involve both a single canalicular, the upper or the lower, and it can involve both the canaliculars, in which it is called bicanalicular. In any of these cases, a repair is imperative to prevent scarring and a post-traumatic epiphora. There are various stenting options available for us for a monocanalicular intubation, like a medium tube or a silicone tube, which are expensive and usually unavailable at emergency hours of patient presentation. At such times, a simple and inexpensive but a comparable option like an angiocatheter for 24 gauge, which is easily available and handy, comes to save us. The objective of this study was to determine the anatomical and functional outcome of a monocanalicular lead laceration repair with angiocatheter cannula. It was a retrospective analysis of 9 patients with lower canalicular lacerations. All underwent a primary procedure of repair with a 24 gauge angiocatheter cannula, and the duration was 6 months. The primary repair was done within 12 hours of presentation. The technique was a regional block, and a general anesthesia for pediatric patients was preferred. Local parts were painted and draped with good exposure. A nasal and a temporal cut ends of the canaliculus were identified. The nasal end was located by irrigating the opposite canaliculus with normal saline, and in few cases where it couldn't be identified, methylene blue dye was diluted, and then it facilitated the identification. The temporal lacerant portion of the canaliculus was dilated and probed gently by Bowman's lacrimal probe, and the tip of the stellate of a 24 gauge angiocatheter was slightly retracted into the lumen and gently introduced into the same punctum, into the lacerated wound. Then it was gently introduced into the nasal end until it snugly fit into the canaliculus, and the stellate was withdrawn completely. Normal saline was flushed to the hub of the angiocatheter, which confirmed the alignment, endocanalicular alignment and patency. The mucosal walls were approximated by 9-0-ethylone. Lead laceration was repaired with 6-0-white, and the hub of the angiocatheter was anchored to the skin with a stay suture and 3M microprotape, which ensured an in situ hub. Post-operative oral antibiotics and NSAIDs were given. Topical antibiotic and a steroid combination was started for the patient, and the patients were reviewed on day 1, day 4, and weekly. Why a in situ hub? This in situ hub was kept because it facilitated an endocanalicular alignment and the patency of the repaired canaliculus during follow-ups. And why just not keep the cannula by severing the hub? Because we had some patients in which we found that the severe end would constantly rub at every blink the limbus and the cornea and give rise to erosions, and we had a patient with an ulcer also. The pitfalls, it leads to a cosmetic blemish. Not everyone would like to have that hub hanging around them. Tendency for slippage due to the weight, and early auto extrusion. The results, 9 consecutive patients with lower canalicular lacerations were evaluated. The mean age of presentation was 14.7 years. The range was 3 to 27 years. There were 3 female patients and 6 male patients. The mode of injuries was 6 of them had injuries due to sharp objects like the hook of the blouse during breastfeeding. This was child. The sharp corner of a table, metal plate of a car, foot ruler while playing with sibling. This was a 3-year-old child. Iron hook while unloading luggage from the truck, and sharp stone while traveling from the Mumbai local rail, where we really have these incidents very frequently. And 3 3 other patients had blunt trauma by FST. Successful outcome was measured by anatomical outcome was defined as a maintenance of the normal lid contour and absence of any lid deformity like ectropion or notching. And functional outcome was defined with patent canaliculus and absence of epiphora. 7 patients achieved both anatomical and functional outcome on follow-up at the 4th week. And 2 patients experienced a surgical failure, but only one of them experienced epiphora out of the 2. The frequency of angiocatheter auto-extrusion was found. 2 patients had auto-extrusion in a week span, 5 patients in the 2nd week, 2 patients in the 3rd week. The discussion part, why to repair a monocanalicular laceration when the other is patent? This is the first question which comes to our mind. We do not have a lot of studies having a base that we cannot predict which patient will remain symptomatic after just leaving it like that. Because some of the patients are primary tear drainage from the upper canaliculus, some are from the lower canaliculus. There is no such test available which can actually tell us that the patient is a primary tear drainer from upper canaliculus or from the lower canaliculus. So a repair is imperative, and in every case it is justified rather than leaving it like that. Besides, it enhances the probability of mucosal healing with an endocanalicular alignment and also prevents restenosis. It prevents long-term.
Your time is over. Please summarize in one sentence.
It is a savior. The lacuna, it is not a definitive option, and the duration of stenting is yet controversial. So to conclude, the use of a 24-gauge angiocatheter has been observed to give good anatomical functional results in our pilot study. Besides, but a definitive elective procedure will always rest in the enzyme.
How did you keep the catheter?
Yes.
How long you keep the catheter?
Till it auto-extrusion. All our patients had auto-extrusion of the cannula. So the first was 2 of them. At least the stenting should be there. Endocanalicular support should be there for 3 weeks.
No, 3 weeks is very less. It should be minimum 3 months. And wound maturation takes place after that only. Otherwise, it will. And the hub was kept there, so it is very uncomfortable, don't you think?
Absolutely.
And cosmetically also.
Yeah, but since we had this at an emergency basis, we did it. So there was no other option.
Do you know this surgery should not be done in emergency basis? You can easily wait for 24 to 48 hours. Still, all facilities are available, and you are at a right place, right OT, right instrument, including operating microscope. There is no need to do it within 12 hours or in emergency setting. It is a clear-cut described thing.
That there was a reason for keeping the cannula intact and not only the hub, right? So I would think that some of the extrusions, as you actually rightly pointed out, could be because you were trying to keep a very heavy,
hanging on this.
Exactly. And the second thing I would question is, you mentioned that one of the reasons why you wanted to do that was to keep on irrigating it while it was still in place.
Yes.
It works like a scaffold on which the epithelium can grow, right? So if you want to irrigate it in the meanwhile, you could always actually use the other puncta to irrigate it, right? So that's one way. The second thing is you mentioned about there's a controversy on how long a stent should be in place.
Yes.
I think there is enough in the literature, though I think there is not a specific time, but there is enough in the literature to show that what should be the ideal duration of a stent. So there is not a controversy, I would say that.
You're available for better technique. Why do you want to use this? It's not that expensive, is it?
It's not available.
This is time. See, we have used this for many years. Then why you want to go back? There are better material available now, even from Indian companies.
The point was it was not available at the presentation of patient. Definitely.
You have to keep it in stock. There's no way. AIOC should keep in stock. So I think it's time we should give up this. Dr. Namrata.
I'm here to share some of our experience in managing patients of retinoblastoma with you all. We have no financial disclosures to make. retinoblastoma, as we all know, is the most common primary intraocular malignancy of childhood, primarily affecting children up to 3 years of age. With the introduction of newer diagnostic and treatment modality, overall survival, glow, and vision salvage in retinoblastoma have improved drastically over the past few years. Although the disease is being treated quite efficiently at various centers across the country, we at Arvind Eye Hospital have a comprehensive approach for managing these patients. This includes a thorough clinical evaluation and diagnosis, appropriate treatment, visual and cosmetic rehabilitation, genetic analysis, followed by genetic counseling, and this presentation emphasizes on the importance of same. We did a thorough analysis of all the clinical details of 73 patients of retinoblastoma presenting in our hospital from January 2012 to April 2013. This included old as well as new patients. Only patients with complete clinical data were included in our analysis. Various treatment modalities that we use for treating these patients included chemotherapy with standard dose of VEC, with or without cyclosporin, local chemotherapy in few selected cases, that is subcutaneous injections of carboplatin, focal consolidation measures like transpupillary thermotherapy or cryotherapy, external beam radiotherapy in selected cases, and surgical interventions, that is enucleation with long optic nerve stump or its sparing exentration. Of the 73 retinoblastoma patients that we had, there were 42 unilateral and 31 bilateral cases, 26 being males and 47 females. Leukocoria was the most common presenting sign seen in 81% patients. Mean presenting age for our study population was 17.6 months. Statistically analyzing the age of presentation in unilateral and bilateral retinoblastoma, we found that bilateral cases presented significantly earlier than unilateral ones. On the basis of this data, we proved Knutson's two-hit hypothesis for the first time in an Indian population. Familial retinoblastoma was seen in 14 patients, of whom 12 were bilateral. According to the International Classification of Intraocular Retinoblastoma, majority of eyes in our study population belong to group E. Summarizing the treatment details of these patients, we can clearly see that majority of group A, B, and C eyes responded well to conservative measures like chemotherapy and focal consolidation, while majority of eyes under group E underwent surgical removal. There's an interesting case amongst this case series. There's a small girl whom we saved by our treatment. Her brother was brought to us at the age of 2 years with bilateral retinoblastoma, and unfortunately one of his eyes had to be enucleated for a group E non-responding disease. His mother also had a history of enucleation done at a young age for reasons unknown. On doing a thorough pedigree and family history analysis of this patient, and then doing a genetic analysis of the proband and the mother's blood, we found a heritable mutation in RB1 gene. On the basis of this, we predicted a high risk of retinoblastoma in the next sibling, and hence she was brought to us for screening at the age of 12 days. We picked up bilateral group B retinoblastoma, and she was started on treatment immediately. She was treated successfully with chemotherapy, and today, over a follow-up of 1.5 years, her disease has been regressed. Of the 104 eyes that we had in our study population, 60 eyes underwent surgical removal, maximum being enucleation with long optic nerve stump. Histopathologically, undifferentiated retinoblastoma with high-risk feature was the most common finding. Post-chemotherapy calcification and regression was seen only in 8 eyes. Complete resolution of disease was seen in 61 patients, while 5 patients who defaulted during the course of treatment died due to systemic spread. Average incidence of retinoblastoma has been estimated between 1 in 15,000 to 1 in 18,000 live births. Poverty, illiteracy, and lack of access to health care lead to a delayed diagnosis and higher prevalence of advanced disease in developing countries, which in turn leads to a poorer prognosis in these cases. Our study population had more females as compared to males, although no such sex predisposition has been described earlier. This could be attributed to referral bias. We also noticed that our study population has a slightly higher number of bilateral as well as familial retinoblastomas. Common consanguineous marriages in South India could be a risk factor for the same. On review of literature, we found that rest of the data in our study population was correlating with previous results. Disease-free survival over a period of 1 to 3 years for unilateral and bilateral retinoblastoma were 93% and 72% respectively. To conclude, a comprehensive approach for early diagnosis and treatment, along with genetic analysis at an affordable cost, and its further utilization to increase public awareness is the need of the hour. I would like to share a small video with you all. ophthalmologists can bring a lot of difference in the life of these kids so that they live and see this beautiful world with their own eyes. Thank you for your patient hearing.
Okay, thank you, Dr. Namita.
It has been seen, and it is seen quite often, that if it just happens that the mother's family is the one that has been carrying the gene, a sudden spate of discriminations and all kinds of trouble starts off.
Ma'am, that's actually true. But what we actually, while ventured into the genetics of retinoblastoma, and when we saw this patient, this was I think, one of the best patients that we could have taken for genetic analysis, and we found a positive result in her. And in future prospects that we talk, even in foreign countries, genetic analysis is being done for almost every patient. And this gives a very good prognosticating value to this disease. This life-threatening disease can be checked at the right time if we catch it at the right time, I think.
Excellent work. Just wanted to ask on the same thing. So genetic, you mentioned in your, so what is the, what are the patients, or who are the patients where you always go for genetic, or this was just a one-off case?
No, we have started with.
And this was the only one where you could actually isolate?
No, we have other results also. Rather, till date we have around 14 patients in whom we have confirmed the genetic results. And we are doing the counseling, and we are about to publish the results also.
Yeah, that would have been very good to also put up in the paper. You've done that.
Yeah, I should have done that.
Excellent.
Yeah, thanks.
Thank you, sir.
Last year's Orbital Oculoplasty Award winner on our experience with eyelid sparing orbital exenteration by Dr. Sabri Desai. Oculoplasty at Elvipsar Eye Institute, Hyderabad, and she has won 2 awards on video films and presentations, and spoken at various national and international conferences as faculty. Dr. Sabri Desai.
Good morning, colleagues and friends. I will be presenting my paper on our experience with eyelid-sparing orbital exenteration. I have no financial disclosure in this presentation. Orbital exenteration is the surgical removal of all the orbital contents, including the periorbital and the eyeball, and often patients are left with this kind of picture. It's a radically mutilating surgery with the concept of losing everything and can act as a social stigma for the patient. There are 3 types, which can be total or eyelid sacrificing exenteration, where the entire thing is removed, as in this case, or subtotal or eyelid sparing exenteration, and extended exenteration with the removal of the diseased bone. The indications are malignant orbital tumors, which are primary, secondary, or metastatic, benign tumors, life-threatening infections such as fungal infections of the orbit, secondary orbital tumors, also very common. In the malignant orbital tumors, eyelid tumors comprises 43.3% of tumors, ocular tumors such as orbital uveal melanomas 24.2%, conjunctival tumors 13.1%, and then paranasal sinus, nasal cavity, and lacrimal fossa tumors. Many of these tumors are very aggressive and have, at the extent of orbital invasion, is significant, and the biological behavior is extremely malignant with perineural invasion, giving rise to an exenteration. The reconstruction techniques for exenteration are local solutions, which can either be spontaneous granulation or a split thickness skin graft, regional using a temporalis muscle transfer or a temporoparietal facial flap, or distant solutions. Usually in these cases, healing takes place in 3 to 4 months with frequent anterior bacterial pack dressing done and delays the final outcome. Our paper is a single-center retrospective interventional case series from 2009 to 2012 at PD Hinduja National Medical Hospital in Mumbai. It was an eyelid-sparing exenteration technique was done and described by Goldberg et al. With the modification of the eyelid-sparing method by Costin and Small. All patients underwent an intraoperative frozen section margin clearance. The technique was all patients were taken under general anesthesia, eyelid margins were sutured using 40 Mercel, and an upper and lower eyelid transverse incision, skin muscle deep, was made 360 degrees. This was dissected right up to the orbital margins. An area of clinical palpable edge of tumor was identified. A 4 mm incision away from this edge was made to preserve skin. A skin muscle flap was then dissected as is shown here for 360 degrees right up to the periosteum up to the orbital rim. Then the underlying bone was exposed and the periosteum was incised and elevated from the orbital rim 360 degrees up to the orbital apex, and the entire exenterated cavity was cut with enucleation scissors, maintaining hemostasis so as not to prevent bleeding, including a hypotensive anesthesia. Further, a 1 mm separate skin and muscle margins were excised all 360 degrees and sent for frozen section margin clearance. The eyelid flaps were then sutured only after margin clearance. The eyelid flaps were closed in 2 layers, with muscle being closed with 6-0 vicral interrupted sutures and skin being closed with 5-0 muscle interrupted sutures. Suture removal was done on the 8th post-operative day with attention to local wound hygiene. If required, post-operative aspiration of altered blood was done for 3 to 4 days, and this is a specimen of the exenterated cavity showing an eyelid sparing technique. These are our results, which are 6 cases. We had 4 males with 2 females. We had 3 conjunctival tumors, 2 lacrimal gland tumors, and 1 intraocular tumor. All patients underwent an frozen section clearance for the margin, and histopathological diagnosis was made. In this, post-op radiation was given to 5 patients, only not for the conjunctival amelanotic melanoma. In this 6 patients, 1 patient underwent a small dehiscence 2 months after radiation. However, it did not decrease in size and was stable. The time to wound healing from surgery was 4 to 5 weeks, at which point they were fitted with a prosthesis. There were no tumor recurrences or metastasis at 24 months follow-up. These are some of the complications which have been listed in the literature, which is fistula formation, tissue necrosis with eschar formation, a chronically exposed bone infection, and a CSF bleed, none of which we faced or had in our series. This is the first case, which is an 18-year-old boy with an amelanotic, rapidly growing conjunctival melanoma adherent to the scleral coats and the medial rectus muscle, underwent an orbital exenteration. This is a 10th day post-operative picture at 5 weeks with a left eye exenteration prosthesis. A squamous cell carcinoma of the conjunctiva. This is 8th day, showing the presence of sutures and a well-contracted lined cavity at 5 weeks. And this was a farmer, so he did not want any prosthesis. These are axial and coronal cuts of the CT scan showing a well-lined exenterated socket right up all the way to the apex. This is an intracoroidal melanoma, similarly showing a well-lined cavity and a well-lined cavity being seen on CT scan. So results, all patients had a CT and MRI of the orbit pre and post-operatively, especially post-operatively at 6 months and 1 year follow-up. No patient had any metastatic disease on PET scan investigation at 1 year. 1 patient had a post-op wound dehiscence post-radiation, and all were fitted with high-index polycarbonate protective glasses, whether they had a prosthesis or not. To conclude, conjunctival eyelid and lacrimal gland tumors are frequently seen and are quite malignant. Eyelid-sparing exenteration can be done for these especially for tumors which are not invading very anteriorly. The advantages of this method is a rapid healing, a well-lined exenterated cavity, earlier fitting of prosthesis with an acceptable cosmetic result for the patient. The clearance of these highly malignant tumors is in the literature seen to be more than 60%, and in subtotal 80%, of which we had a similar result with no recurrences and no metastasis on a 2-year follow-up. It's always good to do a collaboration with a medical and radiation oncologist for all of these patients. Thank you.
Thank you, Dr. Savitri, for excellent thing. I want to know, you have spared the eyelid.
Yes.
But they are also basically lining the orbital cavity.
Yes, skin.
So what is the use of having cilia, eyelid margin and all? If skin is enough, it's just for my, because I am also doing a similar thing.
Yes.
But there is no use of lid margin and cilia while lining the orbit. This is what I feel.
No, we don't leave the cilia. The cilia are removed, Dr. Gupta. The incision is made 4 millimeters away from the ciliary margin, so that the cilia are all removed and only the skin and muscle flap is lined.
So this is not eyelid, only skin is sparing basically.
Yeah, this is a technique which
sparing the skin only.
Yeah, but instead of
just to line, and it will line only the anterior half of the orbit, not full one.
No, it lines the full as is seen in the pictures. We suture it and it retracts on its own over 3 to 4 weeks.
Yeah, that is good. That is okay, but it cannot line whole of the orbit. There is not so much of the skin. And in some cases, the skin should not be preserved like adenoid-cystic or carcinoma and all. The skin may also be involved, although you have done a frozen section thing. And in the indication you have written, though that is not a part of your work. Metastatic disease also you were doing exentation. What is the idea there? I don't think there is any idea.
That is an indication for
Indications.
malignant tumors, which were given in theory textbooks. We have
No,
not
that
selected those
just
cases. Yes.
for discussion sake for the
Yes.
young
Yeah.
ophthalmologists.
Yes.
Because metastatic disease in the, I don't think exentation should be done as a primary thing. It is better to manage the disease systemically.
And with that, yes.
Thank you very much.
Thank you so much.
This paper selected from MP State Ophthalmological Society. This will be evaluated. Is it looked or overlooked?
Good morning, respected chairpersons and all. I have no financial disclosures. Ophthalmomyiasis masquerading as periorbital cellulitis or conjunctivitis. Is it looked or overlooked? Ophthalmomyiasis is an infestation of the human eye by the larval form of certain flies. It may be external when larvae present in conjunctiva or internal when intraocular penetration of the larvae occurs. Many dipterous flies have been reported to cause the myiasis in human and or domestic animals. This report was the department in the month of March and April 2012. Out of the 8 cases, 4 denied the history of any hit by the fly, while case number 1, she got the complaints when she was chopping the mutton and rest of them were working in the farm. Most of them came with the presenting complaints of the foreign body sensation, mucoid discharge, conjunctivitis and chemosis. These are the presentation at the time of their complaints. It was lid edema, chemosis, conjunctivitis with mucoid discharge, subconjunctival hemorrhage. On slit lamp examination, it revealed a small 1 to 2 millimeter long translucent organisms with a black head over the conjunctiva. The organisms were motile and actively avoiding the light of slit lamp. The larvae were present in all the cases, crawling here and there. It was in case 1, it was low fornix, bulbar conjunctiva near the punctum, near the lid margin. The leads were everted under the topical anesthesia in all the cases, and the larvae were removed by the fine smooth forceps under the operating microscope and fixed in formalin. After removal, the affected eye was irrigated copiously with the normal saline. Topical antibiotic steroid combination eye drops were given 4 times a day with antibiotic ointment at night time for a week. Next day, the FPX mount slide was made. Larvae were measuring 2 by 0.5 mm with a characteristic translucent body with a dark black heads. The follow-up examination on subsequent day in case number 2, 4 and 6 showed the residual larvae which were removed. The ocular symptoms have largely resolved in all the cases except for the case number 4, where a mild conjunctivitis persists resolved in next 5 days. These are the crawling maggots. Whenever we show the slit lamp light, they are photophobic and moving towards the palpable conjunctiva and bulbar conjunctiva. So whenever you want to remove it, is very difficult because they have a oral hooks by which they go in subconjunctival space, and we cannot remove it only by irrigation. So it is very important first to see them and second to anesthetize them so that we can remove that in time. So we are putting topical drops, and after putting the xylocaine, they are anesthetized. See, now they are not moving at all. Whether they are present in bulbar conjunctiva, also in palpable conjunctiva. So after eversion, we are trying to remove it. When we are trying to remove it, their oral hooks are inside the conjunctiva, so it is difficult. Try to remove it in toto, otherwise that oral hooks will remain there and may cause conjunctivitis. So this is how they are removed. On examination under the microscope, the organisms were identified as the first instar larva of Oysters ovis. Thank you to Dr. Titi Banerjee. This is ZSI Institute, where we send these slides for the identification of taxonomy of this organism. These has a segmented body covered by tufts of numerous brown hooks. Anterior end of the larva, but 2 oral hooks were present. The oral hooks are connected to the cephalopharyngeal skeleton, and the caudal end had a terminal hooks arranged in 2 scallops. Various species of the flies are able to provoke the human ophthalmomyiasis. It was first described by James in 1947. The cases of ophthalmomyiasis by the sheep-board fly has been documented from the different parts of the world. However, there are only few case reports from the India, and to the best of my knowledge, it is none from Madhya Pradesh. Morphologically, the sheepboard fly is a large yellowish grey fly about 10 to 12 mm long. Its larvae can parasitize the host soon after its birth. In its normal life cycle, the adult female deposits the larvae around the nostril of the sheep and goat from where they migrate into the sinuses. The larva mature by going through the 3 progressive stages. After several months, the third instar larva passes out of the sheep and goat nostril and pupate on the ground. The adult fly emerges from the pupa 3 to 6 weeks later and lives approximately for a month. The usual host is sheep, cattle and horse. Man may serve as an accidental host. The fly deposits the larvae near the eye of the human with a stream of larvae while it is flying. So the irrigation of this conjunctival sac with the normal saline is unsuccessful because the organism grabs the conjunctiva firmly with the help of a pair of coral hooks and numerous brown hooks on each of the body segments. So after anesthetizing the conjunctiva, the larvae should be removed with a cotton swab stick or a plain smooth forceps under magnification. Literature reports it may cause preseptal cellulitis by human boat fly, internal posterior ophthalmomyiasis by spotted flash fly, orbital myiasis, anterior orbital myiasis by human boat fly, anterior ophthalmomyiasis interna by blowfly. Thus, the periorbital cellulitis or conjunctivitis, especially in spring season or summer season, with or without the history of insects striking the eye, must be carefully examined to prevent the undesirable responses. Awareness of larval conjunctivitis in the rural areas, especially during spring and summer season, will lead to a more prompt diagnosis and institution of the specific therapy for the disease. Since the larva is photophobic, it is prudent to look for them in the furnaces and discharge. Prompt removal of the larva conjunctiva help in relieving the symptoms. In India, we cannot prevent the condition like this, but to prevent ophthalmomyiasis, we cannot live like this. So to conclude, ophthalmomyiasis is an underdiagnosed condition. We as an ophthalmologist need to be aware of this entity. Any type, and they have a special zoonosis and they do the taxonomy.
Microbiology department, they can also do. Microbiology department.
So they are the final words, Zoological Survey of India.
Well, that's excellent work and it's very good, commendable that you went to the extent to find out more. Only one question is, having known about this and now that you know that this could affect a particular group of people who could be at risk.
Yes, sir. So when we sent it, actually I'm working there since 15 years, but this is for the first time in a 1 month we got 8 cases. So when we sent this sample over there, they also asked, is it the epidemic going on? When we searched, what was happening is there are cattle ship yards were crossing from Rajasthan to MP. So they were staying in that area. I am from Diva. So in the rural area, they were staying for a month. So it was correlated in that way that maybe because of the ships and gods in that area for a more longer period caused the epidemic.
Is there any slaughterhouse or butcher thing around?
They are open also, but sir,
your medical college.
In 2013 I have waited for.
That is a common thing.
Sir, next year then I waited for long. So all the connectivities I was looking very carefully so that I get more cases.
No,
but surprisingly this time we got only one.
I just wanted to know, how did you suspect this? Well, they were visible on torchlight or you see
all
the cases
on
on
the slit lamp? That is
so I want to know, do you see all the cases on slit lamp conjunctivitis cases?
Sir, that is
so how do you suspect?
My message was by the complaint.
Yeah.
By the complaint.
What
The first case when I got, it was a simple conjunctivitis. She came to my place in the night, 8 o'clock, while she was chopping mutton.
Yeah.
Then I saw on the slit lamp and I got the...
So what was the complaint?
She was complaining of foreign body sensation was the first, and this...
No, the foreign body is there in conjunctivitis. I have seen patients...
No, because she came at my home in the 8 p.m. in the night. That's why we got...
No, some patients...
If it is in OPD, yes,
Yeah,
we go by torchlight and we can base it so many.
Some patients clearly say something is crawling. I have
Yes.
seen 2-3 patients.
So
You
that
have-
is
you
the
have
message
mentioned this thing
that
also.
because she came and then we goes and last year we tried a lot, we got only one case. So maybe somehow there was an epidemic that year. Thank you.
The next paper is on lacrimal sac masses, a clinical histopathological case series by Dr. Namrata.
Good morning, everyone. Here's another short case series on clinical and histopathological features of lacrimal sac masses. We have no financial disclosures to make. Primary lacrimal sac tumors are extremely rare and only few isolated cases have been reported so far in literature. Most of these cases present with features like chronic epiphora, chronic cystitis or lacrimal sac masses. Histopathologically, these tumors can be broadly classified into epithelial and non-epithelial neoplasms. We retrospectively analyzed the clinical and pathological details of all the patients who underwent lacrimal sac biopsy from January 2010 to 2012 in our hospital. Only 9 patients underwent sac mass biopsy over a period of 2 years. Sac tissue in all the cases was subjected to histopathological evaluation by eosin and hematoxylin staining, and immunohistochemistry was done wherever required. Of the 9 patients, we had 6 females and 3 males, mean age of presentation being 49.4 years. Best corrected visual acuity was 6 by 6 in 8 cases, while one of the patients had an enucleation done for a painful blind eye a few years back. Summarizing the clinical and treatment details, we can see that 3 patients presented with features of chronic cystitis, and another 3 patients had an associated suspicious sac mass. 1 patient presented with history of chronic epiphora and epistaxis, while 1 patient had a recurrent sac mass. 1 53-year-old female presented with a sac mass and a suspicious preauricular mass. Diagnosis in a majority of the cases was made clinically, while CT scan of the orbits was done in only 2 cases for confirming the diagnosis. Surgically, 4 patients underwent cystectomy, 1 of whom also underwent an incision biopsy from the preauricular mass. Another 4 patients underwent cystostomy with intubation, while 1 patient with recurrent sac mass underwent needle orbitotomy, exploration, and mass excision biopsy. Is a 53-year-old female with a lacrimal sac mass and a suspicious preauricular mass. Another case of recurrent sac mass is CT scan showing a heterogeneously enhancing soft tissue lesion in the region of lacrimal fossa. Primary lacrimal sac tumors are extremely rare and predominantly epithelial in origin. Only 9 patients underwent sac mass biopsy in our hospital over a period of 2 years, which itself indicates the rarity of its occurrence. Mean age of presentation for our study population was 49.4 years. Most common presenting signs in our case series were chronic epiphora with cystitis, followed by sac masses, and similar findings have been reported earlier. Female-male ratio for our study population was 2:1, although no such sex preponderance in lacrimal sac masses have been described earlier. Various imaging modalities like cystography, CT scan, or an MRI can be used for confirming the diagnosis on all such cases. While in our case series, only 2 patients underwent CT scan for confirming a diagnosis. Of the 9 patients, we had 7 benign and 2 malignant lesions. Review of literature indicates a 55% malignancy rate for sac tumors, and this variation could be attributed to an extremely small sample size of our case series. Various studies and case reports on lacrimal sac masses have identified benign tumors like papillomas, neurofibromas, plasma cell granulomas, and fibromyxomas, while malignancies like squamous and transitional carcinomas, hemangiopericytomas, and sarcomas have also been identified. Our case series had 7 benign neoplasms, 5 being plasma cell granulomas, a case of pigmented neurofibroma, and 1 fibroangiolipoma. One of the patients with a plasma cell granuloma of lacrimal sac had a preauricular mass, incision biopsy from which was suggestive of cystadenoma with fibrotic granuloma. As she also had a history of enucleation done for a painful blind eye, we went through the histopathology of the enucleated globe, and we found that she had been suffering from necrotizing scleritis. This itself could indicate a spectrum of idiopathic inflammatory orbital disease. Plasma cell granulomas have been identified in literature as uncommon inflammatory pseudotumors of lacrimal sac, and surgical excision remains the mainstay of treatment. Primary neurofibroma of lacrimal sac are rare and usually benign, although malignant transformation has been observed in few cases. Malignant neoplasm in our case series were a case of biphasic sarcoma and an interesting case of pigmented dermatofibrosarcoma protuberans, popularly known as the Bednar tumor. In this patient, we had a typical histopathological finding of spindle-shaped fibroblast-like looking cell arranged in storiform patterns and pigmentation. Diagnosis histopathologically, this case was confirmed by doing an immunohistochemistry which came positive for CD34. CD34 is highly specific for Bednar tumor. To the best of our knowledge, Bednar tumor of lacrimal sac has not been recorded so far in literature. Complete surgical excision remains the standard treatment of choice in benign masses, while malignant tumors may require adjuvant radiotherapy or chemotherapy. 7 patients had no recurrence in our case series after surgery over a follow-up period of 1 year, while 1 patient with biphasic sarcoma who was advised external beam radiotherapy was lost to follow-up. To conclude, the acramal sac tumors must be considered as a differential diagnosis in patients with chronic epiphora. Thorough clinical evaluation, medical or surgical technique and identification of suspected masses form the key for better management in all such cases. Thank you.
Thank you, Dr. Mehta.
According to the literature, we were suspecting that only.
So when you look at the patient,
Yeah.
so first of all, why didn't you do preoperative biopsy? One thing. Second thing, in epithelial tumors, they have a tendency to grow along all the mucous membranes. So how could you do just a DCT?
So actually,
In large number of patients, you have done only DC.
yes, sir. So these patients actually basically presented only with features of chronic acrocystitis, and a biopsy was not planned. Like we just treated them like normal sac patients. When we took them for surgery on table, we found a suspicious mass. So it's a practice that we send the posterior flaps for histopathology, and along with that, we send the sac tissue. Fortunately, in our cases, we got only benign lesions in those cases. But as a protocol, I feel like if we have a suspicious sac mass, we should first do an incision biopsy, and if something comes positive, we can plan a proper exploration and along with other treatment modalities if it's a malignant thing. Benign lesion, we can just excise.
So they are firm masses, no? They cannot be confused with acrocystitis. Even mucocele cannot be confused with firm masses. There is a term known as the intrinsic lacrimal tumors, extrinsic lacrimal tumors. There is a triad for presentation of tumors.
We should have looked into all this.
Was there any tears in the blood in the tears?
No, sir.
Hemodichlosis?
No, sir. None of the patients of these 9 patients. They didn't have a blood stain tears.
Dr. Namrata, a very interesting case series, and it might be good if you can give us a ballpark figure of total how many SAC disorders you've seen in those 2 years. That would give the audience an idea of what the possible incidence would be.
Ma'am, these 2 years, actually this data is only from Arvind Eye Hospital, Madurai.
Yes.
But our pathology department received samples from all the other centers as well. So we had, from other centers, we had cases of rhinosporidiosis also. And the rest of the masses were these.
What I'm talking about, general DCRs, DCTs, how many? It would be probably thousands.
How many numbers do we do and how many cases did we come across masses?
Yes.
Numbers would be, like exact I cannot tell you, but it was in thousands only. And acramal sac masses were only these 9. We didn't have masses in any of the other cases. For a period of 2 years.
Okay, thank you.
Thank you, sir.
So, practice. Fevikwik not only joins but also heals. I request Dr. Venkat Ravi Kumar to present the paper.
Good morning to all of you. I have no financial difficulties or only temporary and needs corneal protection while the patient is waiting for definitive treatment or treatment of underlying disease process. If proper care is not given for the cornea, it can lead to several devastating complications like corneal perforation or even endophthalmitis. All possible measures must be taken while the patient is recovering from the primary disease, which includes temporary torsorrhaphy and later, if necessary, surgical torsorrhaphy. This is one gentleman who presented with severe exposure keratitis following fall of dust in the eye, and we have used Fevikwik temporarily to close the eyelids to provide a corneal protection, and we were happy with the results within 2 weeks. This is one more patient who also got benefited by Fevikwik temporary torsorrhaphy while he was recovering from Bell's palsy. Inspired by these results, we started recruiting, doing a prospective study, recruiting all the cases of exposure keratitis during a span of 6 months in from July 2012 to December 2012. And we have excluded those patients who are having chances of corneal perforation or corneal melt or microglial keratitis. We have followed up the patients for a period of 3 months, and the success was defined as a progressive clearing of the cornea or intactness of torsorrhaphy on the successive follow-ups. Where torsorrhaphy effect was lost, even after three attempts, we have classified it as a failure. This is the first patient who presented with lagophthalmos and exposure keratitis on a topical anesthesia.
anesthesia, we have cleared the lid margins, dried, and applied Fevikwik using a lid cap of a syringe and closed the eyelids, and this is the result. This is our second patient with the Bell's palsy who was similarly treated, and we have little bit debrided the epithelium of the cornea with a DP blade so as we can enhance the adhesion with using the Fevikwik. This is an old lady again who presented with the Bell's palsy who was treated in a similar fashion. And here we have used bipolar coffee with the lowest power to debride the epithelium where we wanted the strong adhesion. This one gentleman with herpes zoster, where here also we wanted a very strong adhesion. So at the site where we wanted to apply the Fevikwik, we have debrided the lid margin epithelium, dried it, and then applied the Fevikwik in a controlled manner. This one more lady who underwent a neurosurgery, but unfortunately the corneal care was not given. And in this lady, in spite of 3 successive attempts, torsorrhaphy did not stay even for 1 month. So we have resorted to surgical torsorrhaphy after 1 month. So 4 out of 5 patients we were successful using the Fevikwik temporary torsorrhaphy. One patient, the last patient, had a failure, so we resorted to surgical torsorrhaphy for her. Mean detention time was 30 days, and it is clear evident in the literature that inadequate lid exposure can lead to exposure keratitis. The idea of glue torsorrhaphy came into picture because some of the causes of exposure keratitis is only temporary, and the alternative, which is present as a botulinum toxin, has its own constraints of cost and expertise and availability. And what is new is only use of Fevikwik in this, but there are several studies which are published using cyanoacrylate glue torsorrhaphy. Our study had comparable results with the Donenfield study, who was done with the jelly prim. Apart from that, we have an additional advantage of very cheap availability of cyanoacrylate glue derivative, which is a Fevikwik. And in a study done by Eza et al., they have compared various regimes of treatment of exposure keratitis, and they have shown that 75% of British ICUs still prefer jelly prim as a temporary torsorrhaphy in their ICUs for debilitated patients. And in a large study done in Pakistan, it was clearly shown that the mean detention time could prolong up to even 2 to 3 weeks with minimal complications, which is comparable to our study also. And O'Donnell has shown that glue torsorrhaphy is as equally efficient as surgical torsorrhaphy in prevention of extrusion of socket expanders. And even some people have used, like Moon has used lacrimal cannula, which also can be used for the Fevikwik for the controlled application to avoid the spillover onto the cornea. There are several limitations to our study, being a very small sample size. We have not graded exposure keratitis. And one of the main issues is the sterility, which we are trying to discuss with the manufacturer if we can supply a sterile Fevikwik pack. And regarding the spillage problems, accidental spillage, if we follow the manufacturer guidelines like copious irrigation immediately with the distilled water or normal saline, that will avoid devastating complications. We strongly suggest this is not a replacement for surgical torsorrhaphy, but provides only a temporary corneal protection, and valuing patients who either refuse or who are not amenable for surgical treatment, but still further studies are required. Until further study, we can state that this is simple, easily repeatable, and more particularly useful for the physicians. Instead of waiting for the ophthalmologist to come into them, they can give protection while the patients are getting treated in the ICUs. Of course, everybody knows the cyanoacrylate glue is already approved by FDA, and Fevikwik is nothing but a derivative of cyanoacrylate glue. And coming to the safety issue, if we follow the manufacturer guidelines strictly and apply in a controlled manner in the prescribed procedure, a lot of complications can be avoided, which is a myth. Thank you.
Okay, thank you, Doctor.
Cyanoacrylate glue is an FDA approved, but Fevikwik is also a molecule which is derived from the cyanoacrylate glue.
That is true. This is not medical grade.
This is not medical. That is what we were discussing with the manufacturer, if they can supply it in a medical grade. So that we can also...
medical grade is available now in the market.
No, but that is very, very costly. It comes around 500 rupees.
Yeah, but
this is only 5 rupees.
Did you take ethical clearance? Did you take ethical clearance before doing this job?
No, we just took a patient concern. We explained the patient that this is possible. We are trying. That's all.
think, to find a suitable alternative, especially when you are dealing with patients in a prospective manner. Some sort of an ethical, clearance. If you don't have even a local ethics committee or something, because you have to find a balance between cost and what is safe for the patient. If you look at, I just wanted to ask, if you look at the manufacturer guidelines, what do they say? Don't they mention that this should not be applied to skin or anything? What does it say? Because I'm not aware of what it says.
No, this is not actually used for medical things. Just tried it because we are working in a very trust hospital where if I say use of cyanoacrylate glue, which is around 500 rupees, patients will prefer not to use anything and they just prefer to go to some other hospital.
No,
I'm not contending that is the reason that we should use it, but that is a fact.
Which brings to the, from the 5 patients you have, let's say one patient who had some sort of it's a non-resolving, it's almost a permanent 7th nerve involvement or palsy after acoustic neuroma surgery.
Yes.
In those patients, why would you think of a temporary procedure anyway?
Yeah, that is, I've explained. Actually, she was also having cataract. We actually suggested her that she would need a cataract surgery. First go temporary to surgery, then later after this clears, we can go release it and then go for cataract surgery and then go for permanent surgery. So she was not in favor of so many surgical procedures. So initially we wanted to clear the cornea first, so that at least we can take off the cataract. Then we go ahead with the temporary permanent surgery, which we actually did later on for her.
Epithelium and then applies the glue on it. So, first of all, I would be worried at doing such a thing. You're creating a raw surface and then applying a non-sterile, non-medical grade item on that. But however, leaving that aside, pathologically speaking, when the healing process takes place, how would you hypothesize that debriding the epithelium helped better adhesion if you're using glue anyway?
One reason is it is described in the literature, but even in surgical torsography, we are disturbing the epithelium by giving incisions. That is number 1. So the risk is same whether you go in a surgical temporary torsography or...
Surgical temporary torsography, you're using all sterile items.
Yeah, I agree. I agree that this is
unsterile to a raw surface.
That is one point. The second point, while the patient is waiting for definitive treatment, then only we are mentioning it.
No, but how does it add?
By creating a raw surface, the adhesion becomes more stronger.
No, but the raw surface you are covering now with the acrylate, you see, so it is now no more raw. Basically, it is the acrylic, so without, it is a layman thing. Just apply on the thing. Basically, it is adhesion because of cyanoacrylate, not through the structures.
Yes, but for cyanoacrylate to stay on, if it is a very smooth surface, likely chances that it can give away very early. So we tried using creating a raw surface, which was described.
On the contrary, they say you have to dry up the thing.
Yes, sir.
Now you are creating a wet thing, oozing of blood.
No, there is no oozing.
So if you create a raw surface, there will be some oozing.
We used low power bipolar cartridge where there is no oozing.
Okay, thank you.
Periocular wound modulation with intralesional 5-fluorouracil. Case series by Dr. Savi. This side.
Good morning, chairpersons and colleagues. My paper is on non-surgical periocular wound modulation with intralesional 5-FU, a case series. I have no financial disclosure in this presentation. Periocular skin is a highly vascular structure with least prominent scars. Scar formation, however, is defined as a highly regulated tissue response following skin or tissue injury being functionally debilitating and cosmetically disfiguring for the patients. Modulation of scar formation for the prevention and formation of scars is a vital component of eyelid surgery. There are 3 types of commonly seen scars in the periocular area. Contracture scars, which cause tightening and contraction of skin causing impaired mobility, keloids and hypertrophic scars. A keloid is a scar which extends beyond the margins of the original wound, does not regress spontaneously and tends to recur after excision. Hypertrophic scars do not extend beyond the boundaries of the initial injury, undergo partial spontaneous resolution and do not recur after excision. Phases of wound healing are in 3 sections: inflammatory, proliferative and maturation, and non-surgically scar modulation tends to act at any of these three levels. Intralesional steroids has been there since 1960 in the form of triamcinolone acetate as a therapy of choice with good response rates. However, in the literature, the recurrence rates are high from 9 to 50% with multiple adverse effects at the intralesional site. Non-surgical management has newer options with antimetabolites coming into vogue. 5-FU or 5-fluorouracil is an antimetabolite which is a fluorinated pyrimidine widely used in oncology. The mechanism of action is that it acts in the proliferative phase by disruption of the DNA synthesis and inhibiting collagen production, thereby preventing an exuberant scar formation. It also interferes with the transforming growth factor beta and thereby preventing excessive collagen 1, which again gives rise to excessive scar formation. 5-FU was originally used in 1980 for a glaucoma filtering surgery to delay wound healing for the flap. On the basis of this delaying wound healing, Fitzpatrick used it as an off-label use for intralesional injection for hypertrophic scars and keloids and presented his study as a 9-year study in 1999 and said that it is very rare for a scar to not respond favorably for intralesional 5-FU. Scars which were inflamed and red responded more dramatically, whereas scars which were old were less in response. However, they would soften and flatten. Hypertrophic scars responded better, and only pain was the commonest thing that was seen. Our paper, the purpose is to demonstrate the use of intralesional 5-FU and antimetabolite for modulation of periocular scar formation and wound contracture. It is a single-center retrospective interventional case series from 2010 to 13. A preoperative assessment of the scar was done. The technique was that 5-FU was injected intradermally using a 26 or a 30 gauge needle using a strength of 50 milligrams per ml, and a slight blanching of leb of the region was seen. Features of scar reduction were scar reduction size, flattening, texture softening, erythema reduction, peripheral regression in patient and doctor observation. Our results were the etiology was 2 cicatricial ectoprion, 4 post-CLW suturing, 1 DCR scar, 1 post-eyelid tumor excision scar. Of these, 2 were contracture scars, 3 hypertrophic, 2 keloids, and 1 a combination of hypertrophic and keloid. 2 to 4 injections were given per patient at 6 weeks apart. Each site was with multiple injections at multiple sites were not exceeding 0.2 to 0.5 ml and a dose of not more than 1.5 ml given. We had a mean follow-up of about 21.8 months with no complications and recurrences seen in this period. This is the second case, which is a man with a cicatricial ectropion in the lateral 1/3 with a standoff, which was given 2 injections at multiple sites, and the standoff went off and there was no retraction, and the patient did not want any further treatment. This is a young boy with a traumatic suturing done at 3 weeks. However, at 7 weeks, he started getting a hypertrophic scar-like picture with a further erythema increasing and a raised lesion. So 2 injections of 5-FU were given 7 weeks apart, and this is a 2-year follow-up. This is a DCR scar in a lady who had undergone a failed endonasal DCR and had keloid tendencies with a terrible DCR scar. And 2 injections later, there was softening, flattening, and almost near resolution of the scar. This is a post-surgical basal cell carcinoma excision showing a pincushion effect and hypertrophic scar following 2 injections with softening, flattening, and a decrease in the pincushion effect of the scar. This is a periocular traumatic scar in a young boy after trauma, which was with significant erythema, and it was a lateral standoff at the lateral canthus, and 3 injections later there was flattening, softening, decreased erythema, and the standoff had completely gone. This is a young boy with a traumatic accident with a medial upper lid notching and underwent 2 injections at EUA followed by a skin graft and 2 more injections with complete results. This is a trauma patient again with a hypertrophic scar following 2 injections with almost near resolution. So the positives of our study is that this 5-FU intralesional is an economical, non-surgical procedure which can be done in the OPD with recurrence rates, with 0 recurrence rates and no relapse at 2 years. There are no studies in the literature showing the standardized management of specifically periocular scar modulation. This paper is the start of something concrete, hopefully. Standard algorithms around the periocular area can be optimized for our race. This study, to conclude, demonstrates the use of intralesional 5-fluorouracil and antimetabolite for the modulation of periocular scar formation with gratifying results with no complications or recurrences in a 2-year follow-up period. Thank you.